So today we are here to discuss to see the digital workflow for complete denture fabrication. So I'm sure you all must be aware of this picture if you have been in practice for a long time. From the way back dental schools, we used to do these flasking procedures. So complete dentures have been there from long time, and they will continue to be one of the important aspect in prosthetic dentistry. Even if we are not going to fabricate it for the uh, patients in a treatment wise, but then we need these dentures. It is for implant planning as well, implant over dentures. So prior to initiating the implant treatment, we definitely fabricate these dentures. So since decades, uh, complete dentures, removable denture treatment have been using the conventional methods of fabrication. And one of the major limitations, I would say, the porosity is one of the major limitations in this complete dentures, and the bacterial adhesion of for the PMMA, polymethyl methacrylate, and polymerization shrinkage is also one of the major aspects, which is the most the disadvantage of these conventional dentures. The traditional complete denture fabrication process is also relatively long. We know we need to spend a lot of time in the lab. Of course, clinical chairside appointments are there. Apart from that, the lab side steps would be there. So chairside itself, we need minimum 5 appointments. If the lab is in-house, then the fabrication aspect becomes more faster. Otherwise, the lab side, they have to fabricate the part by part, and then we need to do the carry on the clinical work. So, from a practice management perspective, the number of the visits required to fabricate a complete denture via traditional means limits the profitability because the appointments consume more time, and we tend to see we don't get sometimes if there are more patients, we feel short of time for other cases as well. So these are the basic limitations which we find in for the conventional denture. So the evolution then, since then, when we started the treatment, I mean, this is the most practical application that has been being used. The dentures have been used. Slowly, there was a development in the aspects to overcome these porosities and polymerization shrinkage. There was a development in the system. We got something called as BPS system. Now, this is biofunctional prosthetic system. It is designed to work with the body in a biologically harmonious way, maximizing function, giving comfort and natural appearance to the patient. So this is the system which came in with using a controlled heat pressure polymerization procedure, which we also call it as injection molding technique, during which the during the curing process of the denture, there is a constant flow of material into the flask, dental flask, to compensate for the shrinkage. This would ensure a perfect fit. And this itself had a different template altogether, for the setup of the teeth arrangement and how the system was evolved. So this is how we have evolved from our basic denture fabrication, and then we got into injection molding technique for some period of time. We have been doing this, and now we are shifting our focus to the CAD/CAM. So, since the development of CAD/CAM systems have given a new concept for fabrication of complete dentures, so it's called as digital dentures, what we say. So, this digital dentures have changed the denture fabrication workflow dramatically. Digital workflow for the designing, manufacturing of removable dentures, may offer a number of advantages and being increasingly used in dental practice. I mean, they now, since patients are coming when we have employed digital aspects into our practice, we have all the equipments in our chair side clinic, chair side, so in office solutions, so we can have the digital denture make workable for our patients. Definitely, this will reduce the number of appointments. The main advantage of digital dentures is that it will reduce the number of appointments. It is more improved biocompatibility, and the workflow basically is faster, and the fit and accuracy is excellent when it comes to milled dentures, especially. The milled dentures are far better than the conventional traditional denture. So, fabrication process. How do we process these dentures? Basically, there are three types. One is milled, next is printed, and hybrid, both combination of milled and printed. So there are different methods now. You can see this is a milled denture base. The discs are available, acrylic discs, pink color disc. So we design them in the CAD software and the milling process goes on. Similarly, the teeth are milled separately. The teeth and the pink and the white has to be um, done separately. And this teeth are milled in the PMMM blanks again with the different shades coming in from A1 to A2, A3. All the different Vita shade guides are available for us for milling the teeth. Next, we have the option of 3D printing. 3D printing is done this way. So we have the resin available for 3D printing, denture resins, and the teeth sockets and all they come like this. So teeth are printed separately again like this. So these are the teeth that is printed. Now, after printing the base and the teeth, we align them in the sockets. Of those are the supports, what you are seeing, printing supports. We cut the supports and align them for uh, for adaptability and finally for occlusion. So this is the basic methods of process fabrication. And hybrid includes now we can print the base and mill the teeth. And basically, the milled teeth are more superior than the printed ones. Sometimes there might be small porosities that may be porous. The material would be porous when we print. So milled teeth are far better than the printed ones. So we can print the base and mill the teeth and join together. So that joining part is done by different ways. We can use cyanoacrylate resin or composite flowable composite resins also. So this is the video here how the teeth are being printed. You can see the printed teeth. This is the resin tank in the printer. So both upper and lower teeth are printed. Then similarly, the base is printed here separately. So both the teeth and the base are joined together in the patient's mouth, or we can have, if you have done some conventional analog method and where the models are on the articulator, you can do it on the articulator as well. So moving on to the different methods of fabrication, this is the first method where the patient comes to us for a new denture. Now, there are different ways to do it. Now, as we do our conventional protocol, it's like we make the primary impressions, final impressions, and then jaw relation. So till jaw relation, we carry on with the analog method, and from here on, it is shifted to digital mode. So we scan these casts and the aesthetic plate, that is the occlude bite rims or the occlusal rims, and we align it all the data on the software and do the designing of the dentures. So conventional way, what we have been doing, same will be done till jaw relation and further it is processed. Next step is the patient existing denture wearer. So if you have a case where patient comes with old denture wearer and teeth are treated basically, and that's been quite a long time now, and there would be some amount of resorption happening. So in that case, we evaluate the existing dentures, re-establish the vertical dimension of occlusion, occlusal plane, and then make a final impression in a closed mouth technique. So with the elastomeric impression material or a monophase material, we can use and make the impressions like this, and we scan these dentures. So scan upper denture, we scan the lower denture, and both held together in occlusion, we scan. So that's it. We need in first appointment itself, it can be done, and we don't need the patient hereafter because already occlusion is set there. So we start designing on the software. We don't have to pour the cast as well. We can do it on the software and make the model. Next method we have for immediate dentures, like patient is already having few mobile teeth and there is a vertical stop. So we can go ahead directly scan with the help of intraoral scanner, scan the jaws, upper jaw and lower jaw, and then uh, with the help of software, CAD software, we can do the virtual extraction of the teeth, like how we can see in the picture here. We do the virtual extraction, and then the teeth arrangement and the designing is done. So this is the third method. Then we have the fourth method where patient comes to us, a new patient. There are no old dentures here now. We make upper impression, we make lower impression, and with the help of a centric tray, I hope most of you would have seen this centric tray. It's like a triple tray for edentulous. How we use a triple tray for dentulous, same way it is a triple tray for edentulous. So this centric tray basically records the vertical dimension as well as centric relation in one go. So with the help of this UTS CAD, we can record the face. It acts as a Facebook transfer and align the mandibular position to the temporomandibular joint in the software and make the readings there, use the readings for virtual articulation. And in one appointment, first appointment itself, we can acquire all these data and start for the denture designing. So these are the different methods which we can think of fabricating the dentures. Data acquisition is one of the most important things. Like first is the intraoral scans. Now, there is a bit of debate that goes on here whether there should be a direct intraoral scan can be done in the patient for the edentulous cases, since the intraoral scans become the static impressions and they are not functional. Hence, the retention and adhesion, cohesion, all these factors gets affected. Since if that is the case, then you can go ahead and do the regular conventional impressions and do it. But it's a myth, I would call. I mean, I would say because we have done there have been in cases reports where intraoral scans directly scanning has been done of the upper and lower edentulous foundations, and the denture fabrication has been done. So there have been reports in the dental literature. So we can try out this method as well, direct scanning, but it's a challenge. Scanning the mandibular arch edentulous foundation is a bit a challenge. We need to have little bit of experience, hand experience, to control the scanner for scanning the ridge. Next, we have denture scans. If the patient is a old denture wearer, we need to scan the denture. like we discussed in the slide. And then we scan the bite rims, occlusal rims if we have done, and we scan them. Then we have centric tray scans. We have to scan the centric tray, either any one of them. If we have made occlusal rims, we scan them, or the centric tray scan. Then finally, the face scan. This is one of the most important thing now, slowly trending into the practice of digital dentistry, where face scan can be used for smile designing, setting up the teeth, and also recording the condylar guidance, vertical dimension. Everything can be possible with the help of face scan. So here is a case where patient has come to us for a new denture, and I'm just showing you the video of the scanning protocol, how it is being done. You can see the workflow here. So this is a maxillary scan, maxillary, and the maxillary cast, maxillary record base, mandibular cast, mandibular record base, occlusal rims, and then finally merge all the data. So let's see this scanning. The protocol, the scanning strategy for the edentulous foundation. So these are the primary casts, master casts, which have been made with the conventional analog method, and jaw relations have been done already. So we are going to scan the models. Then we scan the upper record base with occlusal rim. Now you can see that we have added some composite buttons on the occlusal rims, because again red color, full entire red in color, the software scanner may not recognize immediately, and the scanner gets stuck at a point. So we need to have some reference points to start the scanning again. So we need to add some composite buttons there on the occlusal rims, and we start the scanning from the tissue surface and slowly extend it to the occlusal surface. It's a bit tricky, little bit, till we get hands-on on this. It is not possible. It's not an easy way to go ahead, but it is possible once we start working on this. Then it is just a cakewalk. So the scanner used here is the Medit i500. So we are scanning the occlusal rim. So once that is done, then we go on to the mandibular cast scanning. This is how the mandibular cast scanning is done. Then after this, the mandibular occlusal bite rims, record base and the occlusal rims. Again, we have put some composite buttons there and cured them. We need to start from one side on the tissue surface and then slowly extend it to the. So this, what it does is, like, as and when we are just recording the occlusal surface, the scan gets adapted to the mandibular cast. That's how it recognizes. So we come for the occlusal scan now. So this is how it looks like, both the occlusal rims intact. And those are the composite buttons I was saying as a reference. They will help us to get the proper occlusal scan. So this is the way for scanning for the conventional, as I said, protocol, like we do till jaw relation analog method, traditional way, and from here we move on to the digital way, like what I said now. Next, we have a scanning protocol for existing denture. So patient is already a denture wearer now and previous denture wearer, and we make the impressions and re-establish the vertical dimension of occlusion. Bit difficult to scan the depth sometime because if too much undercut is there, then the light may not pass through the scanner. So we may have to make a way out to so that the light reaches and the scans are proper. So this is how the scanning is done for the maxillary denture. We don't need to pour the cast, as I said earlier. We can do this in the software itself. We can make the model in the software. You can see the existing teeth, how they are worn out. Now, same way for the mandibular denture. We scan the mandibular denture. The scanning of the dentures is much more easier than the previous one because uh, the pink part and white part combination is there, as well as there are many reference points for the reference coordinates for the scanner to identify. So very less chances of getting stuck at a point. And once it is done, hold the dentures in occlusion and then scan them. This is how the scanning protocol for the existing denture. Now, once the scanning is done, we take this data into the CAD software. Now, various CAD softwares are available. First is the one is most popular, that is the ExoCAD, then Blue Sky Bio, Blender for dental, IpsoCAD, Reshape, many more are there. So I just listed few of them which are more popular in use. So each CAD/CAM system come up with their own CAD software, and the denture can be designed. Now here is the case where the impression is made in the existing denture with the help of inversion technique. The maxillary model is prepared. You can see on the right hand side. On the left hand side is the impression. In with the help of inversion technique, the model is fabricated. The model is designed. And once the model is designed, the software will move through a different process in designing. It will first ask us to uh, bring a reference plane, like how we used to do the mounting of the upper and lower occlusal rims on the articulator, on a mean value articulator with the thread twine tied to it, and then we check the plane, and then we do pour the plaster. Same way, the same step here on the software as well. We do that and set the occlusal plane. So you can see that maxillary bite rim is there, and this is how the virtual mounting is done on the software. This is the ExoCAD, and virtual mounting is done. And this is how the maxillary cast look like when you see. Then the first step is to mark the incisive papilla. Now the software will keep asking us the anatomical landmarks. So like how we do the conventional way, like we make the impressions, primary impressions or the final impressions, we try and see the detailing of the recording, the landmarks, anatomical landmarks in the impressions. Same way here as well. We need to give the inputs to the software pertaining to this case, particular case, like where are these very prominent anatomical landmarks. Now, as we all are aware that incision papilla is one of the most stable anatomical landmark in the maxillary foundation. So it has its own significance for several reasons. So we need to mark like this the incisive papilla. Once that is done, next we need to mark the tuberosity. So please see, look into this now. When incisive papilla is done and the tuberosity is done, it is asking a very key points now. Since our central incisors or our incisors are placed 6 to 8 mm ahead of the incisive papilla, and the posterior molar limits limit is up to the just before anterior to the tuberosity area. So it is arbitrarily the AI is calculating the entire mesodistal width of all the maxillary teeth. So this will help us to the AI will automatically place the teeth here now. Later step. Once that is done, the mid palate and raphe is marked there, and this is the labial fullness limit which you can adjust in the software. As I said, the 6 to 8 mm, the ideally the software takes into it. But if we want more, we can adjust that as per the needs of the patient fullness, lip fullness, lip thickness, based on all the documentation, we can go ahead. Now, next would be the positioning of the lateral incisors and the first premolars. So we need to identify the points of lateral incisor and the first premolar, and then the posterior limit of the denture, upper maxillary denture, that is the hamular notches. So this is the after this, it moves to the mandibular cast. In the mandibular cast, it will ask for the buccal frenum and the first premolar area. So we need to mark that, and the lingual frenum. So once the data is given, the software will recognize the midline, and we need to mark the retromolar pad. So again, retromolar pad is one of the most important landmark in the mandibular foundation because it is set in an inclined plane. So it has a biomechanical effect, and also the teeth arrangement is done just anterior to the retromolar pad. All the posterior teeth are related to the retromolar pad from the premolar, first premolar onwards to the second molar. This is the labial fullness which the software will recognize, and then the software marks the crest of the ridge on the model. Then the AI will identify the molar points based on the inputs what we have given. If there is any change in these points, we can always do it. Then it will mark the second molar point. You can see there, it is just anterior to the retromolar pad. This is the maxillary first molar points. Once all these data is displayed, this is how we get to see on the software. We marks three lines there, the limit of the posterior teeth which are going to come. If you could remember, way back in our dental school, we used to do this mounting of the models on the articulator, then mark these lines, the reference lines, and then set up the teeth. So this is the same way here on the software that is being done. Once we click next button, then we get the teeth setup done there. So these teeth, basically the libraries are there in the software, different libraries. So the AI will automatically select one of the tooth library, which is matching for this case now. Now, this is done based on the inputs, what we have given already in identifying the anatomical landmarks. Based on that, the size, length, and all the teeth size are fit, set for the software, and the AI will bring the teeth here now. Now, these are the different lines which we have marked already. And now we can scale up the teeth if we want. as per the requirement of the case. Now you can see I can bring the upper occlusal rim as and when required. I can make it transparent and set the teeth. This is the final positioning of the teeth. After this, we need to set the insertion direction. So usually the maxillary denture, we place it first in the anterior region and then it is placed posteriorly if there is an undercut. If there is no undercut, then it will be the straight one path of insertion from the occlusal view. For the mandibular denture, it will be just from the occlusal view, we place the denture. Once the view is fixed, then the software will ask us to mark the denture border outline. Now, with the help of the shift key, we hold the shift key and the mouse button and keep marking the points, the outer perimeter of the denture, and the border is marked like this. And once the denture is done, then we click on the button, then we can see on the right hand side, the denture is made there by the software. So same way the upper and lower is done. Once that is done, then there is a connector option that comes into picture. We need to connect these teeth as as one segment. And this is the wax up, yellow color wax up on the right hand side picture. What you can see, it's a wax up being done there, digital wax up. Here we can do the carving, festooning. The software itself will do it at its understanding level. But if you want to little more detailing and any particular requirement from the patient, definitely we can go ahead and do all those things. So once the uh, wax up is done, next is the adaptation of the dentures basis to the models. That is done. This is the adaptation. So once the models are adapted, next process is the step is the merging of all the files together and creating a monolith denture. So this monolith denture is used to do a trial in the patient's mouth. Now here we print them with the a single tooth material, color material or one color material, and then we do a trial. If any changes are there or any corrections to be done, like if the centric has changed, we can re-record here and just scan this process and come and do the corrections in the software designed part. So this helps in the uh, in correcting the things if there are anything gone wrong. Now this is how a monolith denture looks like. Sometimes we can give, if everything is fine, if it is good, then we can give these monolith dentures with pink layering done. Now composites are available. We can use the pink composites and layer them to make the pink part. Now on the software, this is how it looks like. The dentures are ready. So the teeth are removed. The sockets are seen like this. There is an offset set for the base where the teeth are fixed or attached. So this is how it looks like, the maxillary denture. This is viewed from the mesh mixture. This is a STL file. Now, four STL files are created. The maxillary denture base and the maxillary teeth, mandibular denture base and the mandibular teeth. Now we can view these STL files on mesh mixture and check. And the teeth are also there here. Same way the mandibular denture. Now these are 3D printed. So once that is done, the teeth are separately printed and the base is separately printed, and we align them together and we use the composite. Either it can be done on the articulator, as I said, or we can do it in the patient's mouth as well. Ask the patient to hold in occlusion, centric relation, and centric occlusion, and then use the flowable composites, pink color, to seal the margins and cure them. So they get cured, and these are the printed dentures. So this is the patient here before and after. Similarly, we can use the smile designing component here. Uh, I'll just show you this case. We can, as I said, we can use the 2D smile designing we have done here on the software. We taken the patient photographs and then aligned it. But if we had the face scan, then we can do the 3D as well, 3D face smile designing. So this is the smile designing module, smile creator module. You can see that dentures has been designed already, and this is how it looks like. So in the scanning protocol, we need to put some colored buttons again. I'll just show you when the photo is rotated there, we can see that we had put some colored points there to mark it on the software, to align them on the software. Now I have put off the teeth. You can see the points there. So I just put a plaster tape on the occlusal rim so that it becomes white and easily scannable. The occlusal rims are scanned easily, and this is how the casts are aligned virtually on the dentures. So the smile creator module is helpful in designing the smile for the patient. So we can set the occlusal plane and all here. And this is a very useful tool in digital dentures. I'll just show you this video. The overjet overbite is adjusted. So you need to see from the different angle. So this is a lingualized occlusion. This option is available in the software. We can set the teeth for lingualized occlusion. We can use optic glaze once the finishing is done. We use the optic glaze. So I'm just sharing my screen here. So the advantages of mill denture is like it will consume less chair side time, and they are stronger than conventionally processed and 3D printed dentures. So fewer chances of microbial contamination since the glaze, the polish finish texture of the mill denture is much more higher than the conventional, the processed denture, and it fits accurately, and the retention and stability are very good, and it is easy to replicate. So anytime we can have the designs are available and we can mill these dentures. So a quick recap like how the dentures, digital dentures can be fabricated. In a conventional protocol, we do the primary impressions, secondary impressions, jaw relation recording, trine, and the denture placement. Now, apart from this, there are also lab steps which are being done. I have not listed them here, but I just listed the clinical appointments, clinical steps. For the digital method one, we can do our primary impressions, final impressions or secondary impressions, jaw relation recording. And from here, we move on to digital model scanning, designing, and 3D printing and denture placement. So basically, first two in one appointment, jaw relation in another appointment, then denture placement in another appointment. So in three appointments, we are going to make the dentures here. We can club as well in method two, primary impressions, secondary, centric tray recording, model scanning, designing, 3D printing, and denture placement. So all these first three can be done in one appointment, condensing the steps, and then last one is the second appointment. So in two appointments, in digital method two, we can finish in two appointments. In method one, we need three appointments, and in method two, two appointments. So this is how the digital dentures being fabricated with different methods. I hope this presentation was useful for you all. Thank you.